so let me introduce our patient panelists first. Down at the end there, Dan Segalin, Dan. And next is Chris. I realize I've been seeing her for like 20 years and I've never pronounced her last name correctly. Hopel. And then Isabel, there you are, right here, who's a patient and a caregiver. And then our panelists. We thought, a lot of these conferences, you hear a lot of talking heads, but now we have like real people who take care of real patients going to talk about what to do. So let me introduce Ken Olivier. Ken is a real doctor, but he's also really the foremost U.S. expert on a lot of the questions that have come up. He's at the NIH, at the National Heart, Lung, and Blood Institute. He's the chief of pulmonary there. He's taught us so much about understanding the genetics of bronchiectasis, particularly of NTM infections. And then next is Shannon Kasper Bauer. Shannon is an infectious disease physician from National Jewish in Denver. And of course, many of you know that National Jewish has been one of the leading center really in the clinical care of patients, particularly with non-tuberculous mycobacteria. And finally, Kevin O'Neill, who's a pulmonary and critical care physician from Wilmington, North Carolina, who's here to give like real-world perspective on how to help patients, and particularly in a location that quote unquote doesn't have a super center for this. So I'm gonna. I just did want to say we had a few thoughts in mind, but of course we want you panelists to lead this discussion. But some of the issues we hear a lot about how to find care in your local community, how to sort of get the multidisciplinary team assembled. We've already heard Julie talk about when to seek other expertise. We do want to, again, say there are active clinical trials going on right now, and we're happy to give you some information about that. We're going to talk about dealing with the laboratory and then some of the issues and hassles of getting medications. And just one last word, the FDA in the United States, of course, controls what drugs ultimately come to the market, and they've been good partners with us. I just want everybody to know, and there is an upcoming meeting next month to look at that inhaled liposomal amikacin. So, Dan.
Thanks. So I'll talk a little bit about the local chapter of the NTM Information Research Group that my wife Elaine and I run together. In 2006, I had NTM, and around that time, we started the local chapter of NTM IR, NTM Info and Research. We provide information to patients and referrals and encouragement, and we have meetings maybe 4 to 6 times a year. And many of the speakers, or some of the speakers at this conference and at this table, have spoken at our group, which meets for around 2 hours. Usually there's anywhere from 10 to 30 people who come. Dr. Ann O'Donnell was the first expert speaker we had a few years ago, and she spoke to our group again recently and talked about the latest developments in bronchiectasis research and treatment. And Dr. Ken Olivier spoke a few years ago, and he spoke about the research you were doing in the inhaled amikacin and the studies you did on prevalence and how widespread it was. Joe Folkenham, a researcher and expert on water from Virginia Tech, he also spoke. And we've had many other speakers. So if you live around here and are interested in being on our email list and coming to our meetings, I can give you my email address or my wife's email address. It's dsegalin, so that's D, and then SAGALYN @verizon.net. Or my wife's email is elaineinwdc@aol.com. And if you don't live around here, but want to find a local chapter of the group, then I would recommend you go to the ntminfo.org website.
I wanted to show the people that are here, and I know some of you will go, oh yeah, that's true, is what I go through twice a day to treat my bronchiectasis. with Pseudomonas, and I have done this since 2007, twice a day, every day. First, I put on this scarf because the multiple masks and nebulizers that I put on cut my hair. So, my granny scarf. Then, my goggles, because I got salt in my eye only once. And then comes the mask. Whoops, I forgot the vest. This is not unusual. To forget something. And then I get my vest on, and then of course you have a tube, but you got to have the nebulizer and the mask. So this is how I go to the door when the doorbell rings. And the interesting thing is, UPS and FedEx don't bat an eye, so I don't know what they see. But because I started with Pseudomonas in my sinuses. So first I irrigate with the 7% saline, and once a day I add prednisone or, well, I'll think of it in a minute, but a steroid to the sinus rinse to help reduce the inflammation, because that's my big problem. And I have an Arabica that I use when I travel. I used to carry the vest, but it's a hassle. And I have not found a huge difference in using a PEP or something like this to bring up the sputum. But it does add to my treatment time. So that's why when I'm home, I prefer the vest, because then it's done all at the same time. Thank you.
So my name's Isabel, and I'm a registered nurse. I've worked for 33 years in Ottawa, which is our capital in Canada. And I lead a chronic disease self-management program. So I see patients who have hypertension, heart failure, chronic pain. I had severe pneumonia in 2013, and by the time 2015 came, someone thought about a CT scan, and I was diagnosed with bronchiectasis. So when I was diagnosed, the respirologist said, there's no funding for education for you. There's only funding for education for people who have bronchiectasis, which is caused by CF. So I thought I was in a great position to do something about this in Canada. So I educated myself. I've been to the first bronchiectasis conference in Hanover in Germany in 2016, and then again last year in Milan, Italy, and again this year. So I started this program about finding all our bronchiectasis patients in our clinic, because I work in family medicine, and I've been educating them, and now there's a program to educate all of the patients who are in the Ottawa area and even a bigger geographic area, and I'm going to actually start training the trainers. So respiratory therapists who are 2 hours away from Ottawa are going to come in. I'm going to train them, because people have education for COPD patients, but there's no specific education for bronchiectasis. So I meet people in my office one-on-one, usually an hour, sometimes an hour and a half, and we go through everything that a lot of Dr. Daniels talked about. We talk about nutrition. We talk about exercise. We talk about the OPEP device. And I give handouts, which I brought here, because when you have an interview with someone for an hour, they go home and sometimes they forget a lot about what we talked about. So at least they have a handout to take at home to guide them as well of what's an exacerbation, which is really a flare-up. Our patients in our clinic, they actually have antibiotics at home. I insist that the physician gives them a prescription, and I teach them when they need to take it, and exactly what we talked about today. It's 48 hours, increased cough, increased sputum production, increased color of the sputum, anytime they know that their baseline has changed. And I also talk about what's a cold. If it's just a cold, they can wait that out. But if they know that this is really something it's a flare-up, they all have sputum bottles at home. They take their sputum sample, They actually put it in the fridge if they can't get to the lab on the same day, and they start their antibiotic until that sputum sample comes back. So this is routine in our practice, which I have developed this program. And I got our physicians actually on board. When I came back from Germany in 2016, I gave what we call a continuing medical education session to our physicians. Because it's an academic clinic, we have residents who want to graduate as primary care physicians. So just to let you know, I can try to answer some questions about self-management. I know someone was talking about weight loss. A lot of patients with bronchiectasis are small. I've been small like this all my life, so I haven't lost any weight. This has been my normal. But small little meals help. When you get nausea, trying to eat like a bird. So small little meals, frequent, and trying to eat something that's not going to make you tired. You're already sometimes tired from doing the airway clearance technique, by doing the OPEP device, making a soup with pasta instead of having a salad where you're going to chew a lot. And we talked about exercise. Of course, a treadmill, sometimes people don't want to get a treadmill. I have one at home, and it becomes a routine. I do my treadmill in the morning before anything else. I do my hypertonic saline twice a day. I shower, I go to work, and when I do my airway clearance technique in the evening, it's before supper. Empty stomach, and we always have to do what's best for the patient. If you're not going to be doing some of the OPEP device, for me, I don't have reflux, so as soon as I come home from work, I put a pillow under my butt, I lie down either on the floor or on my bed, so I have positional drainage, and I do active cycle of breathing. And there's great website, and you can see that on one of the websites they gave today, which is the Bronchiectasis Toolbox. And you can Google active cycle of breathing. There's actually the one I use in my office when the patients come in. There's a great video, and the ladies are from the UK, so you'll pick up the accent. And they teach it really on this. You just do YouTube, active cycle of breathing. The video is there. And so I do that, and actually I cough once a day only, and that's when I do the active cycle of breathing, and I don't cough any other time. And you build up endurance with the gym. So the treadmill, it's always for everybody, not only people who have bronchiectasis. Doing exercises, it's hard for everybody. They recommend half an hour every day. Not everybody does that. But there was talk about not liking a treadmill. I see patients who have chronic pain as well. And a stationary bike is a great way to do exercise. You can do it in front of the TV, and they do sell the recumbent stationary bike if you're not really comfortable walking on a treadmill or going outside. That's one way of doing some exercise. So I'm here, I can try to answer some questions, but there's another website called the British Thoracic Society. If you go on this website, which is a wonderful website, and they have a section for bronchiectasis self-management, you're going to come across something that looks like this. I created this for our patients, so it's adapted for the patients in Canada, but it looks with permission from the BTS. It kind of guides you. If you're healthy, it tells you what to do. What's an infection? What's an exacerbation? It tells you what you should look like and expect, and then it tells you the green zone. If you're doing everything fine, you're in the green zone. If you start not feeling well, it tells you what a flare-up is. It tells you what to do. And again, if you're the red zone, just like a red light, if you're not really doing well, you start getting confused, you're coughing up a lot of blood, you go to emergency. So you can see this on their website, you can print it, and I just have it because I give it to my patients. British Thoracic Society, so BTS, and then just put bronchiectasis in that little search engine, and you're going to see a lot of information there.
I think I'm on this panel really more to talk about kind of the community interaction, and I think there are 2 points to make. One is that for a lot of people that don't live next to a bronchiectasis center or close to it, it's not necessarily, or not really practical for some people to get care at a bronchiectasis center. And there are a lot of ways around that, either collaboration between the bronchiectasis center and the local physician, particularly. In some places there are people that have an interest in bronchiectasis, and sometimes difficult to find, but there are ways to do that. And I think you have to look around a little bit, and sometimes you need to talk to people that have similar problems to try to find the right people for you. And I think some of the comments that were made earlier about second opinions. If you're uncomfortable with care and you're seeing somebody and you're not certain about whether or not they're giving you good advice, and you ask for a second, you say, maybe I should get a second opinion, and somebody says, well, you don't really need it. You need to go find somebody, because you should never be in a situation where you're uncomfortable or uncertain about the advice you're getting. And if somebody isn't willing to send you someplace or isn't willing to talk to another physician about your particular problem, if you're uncomfortable, then you need another doc, in my mind. But I think there's a lot of opportunities to kind of leverage centers, because where I live, there's nothing really of size within 2.5 hours in any direction. So for a lot of people, that's not a practical trip. They need somebody locally to help with exacerbations and things that come up. And a lot of this, I think, can be managed. A lot of can be managed locally if you have the right person, and if you have a good relationship with the physician. So I don't know what questions you all have. I think I'll probably just wait to hear what you guys have to say.
I'd just like to add, I had that problem. I tried 2 different pulmonologists, and then I wrote to National Jewish, and I said, I need somebody that really knows his illness. And I got somebody, which is Dr. Kyle, and it is 2.5, sometimes 2 or 2.5, but it's worth it. And then I'm hoping, as I said to her, I'm also starting a new PCP. She was part of the problem also. That will work for me.
Yeah.
What? Oh, okay. So I just wanted to say that as some advice sometimes to go get somebody that that like National Jewish is saying, this is the right person, and then you can slowly get some back to somebody in your community that will cooperate and know what's going on. So.
Yeah, I think that helps too in terms of being able to get lab work done. Some of the follow-up, even if your primary decision-making is done at a tertiary care center, getting follow-up, having somebody who can monitor for complications, somebody who can interact with the center is very helpful in terms of making sure you get good care. So.
Maybe Shannon, you could talk about the interaction the other way.
Yeah, so I'm glad things worked out. I also, and I think we talk with outside physicians every day. That's just, 80% of our patients are out of state. So we're always on the phone or emailing or working with physicians around the country. And then there are other avenues for doctors to get help without you actually physically coming to. We have a free online consult site for providers to write in and say, I have a complicated patient and we're having trouble with their back therapy, and they may not be able to travel, for example, and can you give us a call back? Or so that's always available too if you have a provider that would like to access that. And I think that goes for several institutions, and I know folks call Tyler all the time and probably call Ken, and so that is available. And then finally, NTMIR, which you've heard a lot about, on their main website, they do have suggestions for providers around the country, and you can just choose your state, and if you wanted to have a list of providers who they recognize as having excellence in care at different parts of the country.
Maybe, Ken, you could, you're the super center, so maybe talk a little bit about clinical trials and maybe about the genetics question that came up before.
Sure. So at the NIH, we've had a long interest in non-tuberculous mycobacteria from a variety of perspectives. The person that I used to work for, Steve Holland, has been very interested in the genetics of infectious diseases, and has done a lot of work to understand better the genetic aspects of the parts of the immune system that control mycobacteria. And many of the people that have full-blown genetic defects in that part of the immune system don't develop disease like what we're talking about. They get widespread infections from these organisms. They get bloodstream infections. They get infections in organs predominantly other than the lung. And when the lung is involved in those patients, it looks pretty different from what we're talking about today. Those patients generally don't get bronchiectasis. They get more of a pneumonia caused by this. But what we're trying to understand are sort of more subtle genetic changes that might act as risk factors. And if you think of a disease maybe like asthma. There's not a single gene that causes asthma, but many people who have asthma running in their families. And so this sort of familial clustering of disease does suggest that there are genetic predisposition or genetic risk factors. And so those are the kinds of things that we're interested in trying to understand better, and there are signals within the patients who have bronchiectasis who have not had a defined cause of it that begins in the 50s, 60s, or 70s and acquire these non-tuberculous mycobacteria that strongly suggests there's a genetic component in some people. And those signals are, again, there can be multiple family members with the same disease. Frequently, they're diagnosed around the same age. It's a little difficult for us to understand that because, again, with a lot of traditional genetic diseases like cystic fibrosis, or people mention the cilia, this other genetic disease called primary ciliary dyskinesia, frequently those diseases will be manifested early in life, and we kind of understand that better. But again, those are sort of full-blown manifestations of the disease. And I think that trying to understand better what this disease looks like in families can help us understand, why it takes so long for it to develop, why many people have, gone through their early childhood, maybe gone through their teens, 20s, 30s, and 40s without significant problems before they start developing cough later in life. So it may be that there are sort of combinations of genes that in and of themselves might not cause that big of a risk, but when you start adding them up and you couple that with exposure over time, that may be enough to result in disease. And so we have studies set up where we're particularly interested in seeing families where there are multiple people involved, because that kind of helps enrich our ability to find genetic changes that can be helpful. We're trying to understand better why many people that have looked at this from an epidemiology standpoint, or when you look at sort of the population as a whole, why it appears to be more common in women than men. And other than the obvious, are there differences between women and men that might either bring this to medical attention more, and there are ways of thinking about that, or are there differences in hormonal changes that might relate to the development of disease? And so there are kind of a variety of questions that we've had along that. And I know that some of you in the room have participated in studies where we were trying to enroll equal numbers of men and women. We got the parts of the study that were trying to enroll women covered really quickly, and then had a very difficult time finding men to participate in that. So Dr. O'Donnell actually was quite helpful in referring several of you in the local area to participate in those studies. So that's kind of helping with our, hopefully, in our understanding of this. And, again, if you get back to asthma and you kind of look at what's developed in that disease, when we thought of this as sort of a single disease where everybody with asthma looked alike, and we tried to apply sort of newer novel therapies to that, it was very difficult to see a signal. They would do these studies with drugs that in a few people looked like they worked. When they'd expand them out to large numbers of people, you couldn't really see an effect. And then as people did more research and they realized that there are sort of categories of disease and certain things that you can measure in the bloodstream, or other things called biomarkers that will allow you to kind of categorize patients within that bigger disease, you can then start applying specific therapies to those people that look more alike in terms of disease manifestations that are now beginning to show signals in terms of effect. And so when we look at the sort of overlapping syndromes that are associated with this, we've known for a long time, for example, that patients with cystic fibrosis are particularly predisposed to developing these infections. And we know that in people that have had no apparent disease previously who develop bronchiectasis later on in life, when we look genetically, there's a very high prevalence of abnormalities in the CF gene. And again, to get CF, you generally have to inherit one abnormality from your mother, one from your father. And so many of these people have one of those abnormalities instead of two, what we usually call a carrier, which tends to predispose to this. So some patients may look genetically kind of more like CF patients do, We know, for example, in another genetic disease called primary ciliary dyskinesia, that those patients are also very highly predisposed to acquiring mycobacterial infections. And when we look at things like cilia function in many people who develop what we call idiopathic bronchiectasis, unknown cause later in life, many of those patients appear to have abnormalities in the movement of the cilia. So that may be sort of another category of patients who might respond to a therapy directed at that. This sort of tall, thin appearance that people have associated with the term Lady Windermere, that appearance and those physical features tend to overlap with genetic syndromes that are called things like Marfan syndrome or Ehlers-Danlos syndrome. And there are a series of genes that are associated with those diseases, and that might direct a different kind of treatment. So we're a long way from, well, at least I think we're a long way from translating work we're doing on genetics to specific therapies, but maybe it's not so far away, because if you look again at cystic fibrosis, there are now specific drugs that target the genetic defect, and not only that gene, but they're targeting specific mutations in that gene to where if you know what your genetic profile is, if you have cystic fibrosis, there are people that can tell you whether the newer drugs are likely to act or not. So my hope is that someday for the disease we're talking about today, we can get a little bit better in defining this in terms of what the underlying causes are, and to begin to address those specific causes on more or less an individual basis and tailor some of the therapies to it. So a lot of our work is aimed at understanding what's different about the people who acquire these infections and acquire bronchiectasis later in life, what predisposes them to that, and how we can sort of tailor therapeutics eventually to improve the quality of life, and improve your chances of not getting reinfected if we can sort of target the underlying cause.
I have a question.
Questions from the audience?
You're talking a lot about physiological causes and underlying cause. Has any of your research looked at the ACE scores for people, for example?
The ACE scores?
That's a childhood trauma measurement.
Oh, not that I'm aware of. I'm sorry.
Okay.
I have a question. You mentioned the older, thin women and the hormonal changes. Would hormone replacement therapy be of any benefit?
That question's been looked at. The question was whether in, with the sort of high prevalence of these infections in older postmenopausal women, would hormone replacement therapy be of any benefit? And people have looked at that in terms of trying to determine whether those hormonal changes do correlate with it. It's not really clear. We published a paper back in 2008 where we sort of did a survey of looking at whether, things in age of onset of the menstrual cycle, whether or not patients were on hormonal replacement or not, and couldn't really tell much of a difference there. So I can't tell you one way or another. I think it's probably more of a more granular answer than that. But as far as I know, I'm not aware of any studies that have shown differences in terms of hormonal replacement and whether that makes a difference in either the disease course or predisposition. Okay. I think there's a question in the back.
Question back there.
For the woman from Ottawa, could you just speak to using your devices when you're feeling well?
Absolutely. So the aerobica I can use twice a day. I'm very dry in the morning compared to some people who will have a lot of mucus production in the morning. In the morning, I feel fine. I still use the hypertonic saline twice a day. In the evening, I would use the aerobica if I have a flare-up, because I found that I didn't get any more mucus out, because postural drainage works for me. Just lying down on my back with a pillow under my bottom and doing my active cycle of breathing while I'm lying back, that works for me. That brings up all the mucus. And once I have 2 clear huff coughs, the mucus is out, I'm done for 24 hours. So the aerobica, I always have it on hand. I travel with it. And if I do have a flare-up, I would start using the aerobica. But I do put it together like we've seen on the picture with the hypertonic saline, so I would use it together. And of course, some of the things I give my patients is how to clean it, but these things have to be sterilized, not only cleaned in soapy water, they have to be sterilized. And something that wasn't mentioned earlier, I recommend it, and this is what I do, I have a baby bottle sterilizer. So with a baby bottle sterilizer, I don't use the one that goes in the microwave. I don't bring any of these things in the kitchen. Just for me, I'm not interested in that. I use it in the bedroom, and it's an electric one. It will survive the nebulizers. Your aerobica will survive at least twice a week to sterilize it. And use distilled water in your baby bottle sterilizer. So it's sterile, it's clean, you know that you're going to use it when there's been mucus in it the day before. So I clean it every time I use it. I'm talking about the nebulizer or the aerobica. Clean every time with soapy water. You soak it 20 minutes. You make sure that you shake it off. You let it dry on a paper towel and never on a towel, because the lint from the towel could get into that next time you breathe it in. So on a paper towel, then you put it away somewhere where there's no dust going in. If you travel, Ziploc, make sure it's sterilized before you travel. And if you do travel, we talked about vinegar. That's not recommended. CF clinics don't recommend that, but you can use 70% alcohol. You let it dip 1 to 5 minutes, no more than 5 minutes in that. You throw the alcohol away after. You rinse it really, really well. You let it air dry. So if I travel to Europe or anywhere, I buy in the States and the Caribbean, you can buy alcohol just in the pharmacy. In Europe, you won't find it. They need a prescription, and it's very expensive. So you have to find a different way to try to sterilize it if you're planning to go to Europe. Barbados, you can do it. Don't worry. You can buy it over the counter just like you can here in any pharmacy.
I have a question for you.
Sure.
Because when I go to Europe, I hadn't thought about the alcohol. Over the counter, you can buy sterile water.
Right.
So I just rinse my equipment out with the sterile water and let it air dry.
Make sure you put some soap. You need some dish soap. So,
Okay.
I mean, what we recommend, if you do YouTube on any of these things for a CPAP machine or people who have CF, I know we're not supposed to mention too many names, but the Dawn, they recommend Dawn dish soap. You can get it at Costco because they say it's a mild dish soap. So you put that in there, 20 minutes, you just let it soak, then you shake it off, you rinse it well, you let it air dry. But in Europe, it's a bit more complicated trying to sterilize your equipment.
Right.
Yeah, so at least you wash it. Make sure it's very, very well washed.
And you wash it then in sterile water.
You can use sterile water. If you open your aerobica book, it'll say use distilled water every time. I mean, in Canada, we don't talk about NTM as much as we do in the States, although we do have a problem with NTM in Ontario. So tap water is not recommended, and when you open the book and the instructions, they will say distilled water. So you can buy that at Walmart or anywhere for $2, any pharmacy, for a really big jar.
Clofazimine hasn't come up in this discussion, and I'm curious about why it was brought back, if there are any test results from using it published.
I think we could all probably comment on this, but so clofazimine is an old drug. It's a drug that's been around, I don't know, since the 50s at least, maybe 60s. It's a first-line drug in leprosy, and it's also used in multi-drug-resistant tuberculosis. It's not commercially available, but it's used widely in NTM treatment for both MAC and for Mycobacterium abscessus. And it's not a first-line drug for those infections, but I personally consider it a second-line drug when patients specifically don't tolerate one of the rifamycins like rifampin or rifabutin. There have been published studies. Again, this is all observational data. There's no randomized controlled trials or randomized trials on this, but it has been shown to be as effective in observational studies. So that's particularly why we use it. When we lose one of our first-line drugs, we often will think about either clofazimine or the inhaled version of amikacin.
I would just mention that there is a clinical trial going on with it. It's at a relatively few number of sites, but one of the problems of studying a drug that's already been approved like that is trying to find funding to conduct these studies. And so this trial took advantage of a novel funding opportunity. It's actually funded by the FDA through their orphan drug program. So the trial is based out of Oregon Health Sciences Center, and there are 2 other sites that are participating, but it's looking at 2 very specific groups. When we try to do drug trials in this disease, since it generally takes multiple drugs to kill it, trying to introduce or understand the effect of a single drug in that multi-drug regimen is very difficult. And so, it's an attractive thought to think about using a single drug maybe for a limited period of time or in certain patient populations from a research standpoint to try to understand if you can see an effect of that drug. And so this trial sort of takes advantage or is using that approach. So this is looking at treating patients who have had positive cultures for Mycobacterium avium complex, but not necessarily showing progression of disease such that, people would say, well, it's probably safe to watch you. We don't necessarily need to start you on treatment right away. So that's one group of people. So people who have disease mild enough that you wouldn't feel compelled to put on 3 drugs right away, and then looking at the activity of this drug over a short period of time. The other population that the study is looking at in people who have had Mycobacterium avium complex have been successfully treated, and then when they're being followed after treatment, may have an occasional positive culture for MAC, and again, clinical stable disease. People are saying, well, we could start you back on 3 drugs, or maybe we could watch you for a while, not feeling definitive about starting back on treatment, but looking for a way to prevent disease from coming back. That's the second group that's being enrolled in this. So it's kind of 2 specific populations, but it's trying to get at, can we see if there's signal that says that clofazimine works, so that we, in the setting of a clinical trial, can feel more comfortable about how we're using the drug and maybe get it a little easier to obtain than it is right now. Yes.
Actually, I'm on it right now.
Mm-hmm.
I started clofazimine in October.
Use the microphone.
I started clofazimine in October. We're very hopeful. I was diagnosed with NTM in '95 and have been on different antibiotics ever since. Never had a negative sputum in all those years. We're just very hopeful that the clofazimine is the only thing that it showed any kind of susceptibility to. It no longer shows susceptibility to anything that I've been on since there, and I'm 61. Yeah. So it's been a very long time.
Yeah, the drug
so we're
is
hopeful.
Approved. It's an approved drug.
Yeah.
We can obtain it. It's a little awkward the way we have to get it, but again, this trial is looking to see if we can find clinical trial evidence that might support, having it easier to obtain. For example,
get a tan.
Yeah, you get a good tan.
I have a question. I'm the support group leader for the Philadelphia area, and I do have a question about getting doctors to speak. We meet at Lankenau Hospital. I have 85 patients on my list, and they love getting my information. But I only have maybe 10 or 12 show up because they just talk to each other. So I don't know how to go about having really good speakers that know more about these things like this come that far to speak to maybe a dozen or 15 people that can actually get there, because many of, well, me included, are an hour, and so is she, an hour from our hospital. So that's for you.
I don't know if there's a magic answer for that. My wife and I try really hard to get people to come to our conference, our events, and sometimes a lot of people come and sometimes they don't. Depends. We're in Washington. We get great speakers because there are a lot of people are around here. So, but even sometimes we get great speakers, and there are a lot of people on our email list, but only a fraction of them show up.
We have Amy Lietman in the back there, who's from NTMIR, and I'm sure we could do more on this score. We have great collaboration. Amy, is the person overseeing NTMIR. Yeah, so I think we can do more on that score, definitely.
And the other thing is, I'm from Canada, but if you have that little card that they passed earlier, they actually have great webinars. So if you're on the internet, they had one of you, Dr. Daly, who was here over the weekend. He gave a great webinar, and you can ask questions and call in. So it's different. Yeah. Oh yeah.
And I told everyone, I was Dr. Daly, my doctor in Denver, and Dr. Mitchell was my surgeon. But it's different when people are there? Because I asked a lot of the people, did you watch it? Did you, you know, it's so wonderful.
Was there another question there? Yeah.
This is not a very pleasant question, but it is very practical, and I've often thought about it. Every day I think about it. Is it wrong to swallow the mucus that you cough up? Is that then spreading the bacteria to your gut, etc.? I can't imagine walking around with a little paper cup, and Kleenex is not always available. And so what do the caregivers and doctors advise about that?
It's a great question that was just asked in that webinar. When we listened to that webinar for Dr. Daly, that was a question that was asked, and it's a great question. Every question is a great question, and his answer was there's nothing wrong with swallowing it. Well, nothing wrong with swallowing it.
Yeah, I can tell you what my colleague would say, Dr. Hewitt. Many of you probably know her. So, yeah, it's probably fine. It's not going to hurt your gut at all. We're all ingesting this every day, right? It's not going to hurt your stomach or your intestinal tract. However, if you're someone that is predisposed to refluxing and aspirating, it can just come back up and go right back into your lungs. So that would be a reason to spit it out if you can.
Some of our local members in DC, and I imagine those across the nation, are sometimes wondering about the research that may have taken place or not into any benefits of medical marijuana for the symptoms of bronchiectasis or NTM or any of the related conditions.
Kasper Bauer, she's the expert.
Yeah,
from Colorado.
Not really, but the short answer is no. We just, there are several people, though, at University of Colorado who are interested in and now are able to study marijuana for lots of different reasons, chronic pain, oncology centers, et cetera. I personally don't know of any related to bronchiectasis or NTM. Have we had patients who've employed that? Yes, absolutely. We've had patients post-op who've used it when they're in Denver. They've used it for cough, too. I don't know if it helps, but certainly not inhaling it in any way, shape, or form. But that's my short answer. The tincture? Yeah, I don't know anything about that either. Are you talking about CBD oil? Yeah.
So the question is cannabis oil, Dr. Kasper.
I work for the
Dr.
federal government.
Olivier. Marijuana is now legal in Maryland as well. So
I think it's a fascinating area of research, and I'll tell you just anecdotally, I have a lot of patients that use CBD topically for their joints for chronic rheumatologic conditions, and we have visualized its anti-inflammatory properties. It's really quite remarkable. So I think it's a great area of research that needs to occur.
That's what I was wondering, if anybody was doing research on it.
I'm sure there are. Yeah, I'm sure there are. I just don't know in our field. Maybe Tim?
With the CBD oil, it's not regulated so that there are a couple of homeopathic or other natural product websites out there we can share that speak to this issue. The problem is that many of those have different products and there's not one standardized issue. Dr. Kasper Bauer shows until we can, like any other pharmaceutical, know that you're getting the active ingredient at a certain particular dose, it's not recommended by these sites that have done reviews just because there's no standardization across the CBD oil products, and there are many, many out there. Some that probably work, some that don't, but there are also adulterated substances in those oils, so one has to be really careful about that.
is there a question? Yes.
Yes, I'm currently on the, as you like to call it, the cocktail of 3 antibiotics for MAC. And I know antibiotics can wreak havoc with gut bacteria. wonder if you recommend probiotics, or what do you recommend to patients like me?
Do you want to answer that, Shannon?
Sure. Uniformly, we recommend it for all of our patients, probiotics. That's just every patient that comes in that's going to go on antibiotics, we recommend probiotics. There's actually, as an infectious disease doctor, there's very few infections out there that require the duration and the amount of antibiotics that we use in our clinic. And I can tell you, it's again, another area of needed research, but we rarely see Clostridium difficile infections in our patients. Maybe that's because we use so much probiotics. There's so many out there on the market, and some people just feel better with certain preparations. So I think we've tended to recommend a preparation that doesn't require refrigeration, so it's just, easier for patients to travel with. But there are many good probiotics on the market. So I would just talk to your local pharmacist.
Thank you.
Yeah.
Hello, I have a dumb question. I have so much mucus in my mouth, but should I get the mucus from my lung? I don't get them. And I'm wondering what's the difference between mucus from my lung and my mouth, and where come from this mucus from my mouth?
It's a very good question. The question is, she mentioned that she has a lot of mucus in her mouth, probably in the back of your throat, I would guess, as well, and that it causes problems with getting things to come up from your lung. Is that correct? Is that what you were saying? How do you get the mucus in your mouth? Yeah, so it's a little complex in that when we sense things sort of in the back of our throat, it feels to us, or it can feel to us, like it could come from either direction. And so sometimes it's from sinus congestion, maybe in the back parts of our sinuses that's draining down the throat, or as was mentioned previously, we're all built with this sort of mucociliary escalator that is propelling this mucus up out of the lungs. And so the question that came up earlier, is it okay to swallow it? Well, normally we all swallow it because we're not going around, coughing and bringing stuff up when we don't have bronchiectasis there. And so in this process of clearing things normally out of the lung, it comes up over the vocal cords. We may clear our throat and then swallow it. And it may feel to you, especially if you're lying down, like you have a lot of mucus in your mouth or in the back of your throat. And it could be either coming down from above from your sinuses or coming up by the normal clearance mechanisms out of the lung.
I wonder if you have a list or could recommend the best online community for caregivers of people with bronchiectasis and NTM.
Well, earlier today there was a slide that had different websites. I'm not familiar with many of them, but I know NTM-IR, or NTM, Information Research, that's a very good group that has information for both patients, for caregivers, and refers people to doctors and providers.
I'm thinking specifically like Facebook groups or just communities of people talking.
Well, Bronchiectasis 3.
Yeah, this isn't my expertise, but if you look at this Bronchiectasis and NTM initiative, these cards, and there's several of them up here, there's a website on there for Bronch and NTM 360social.org, and I would highly encourage all of you to look at this. It's a monitored blog, and so there are people that are looking at the conversations going on there. They are helping to redirect conversations that maybe are kind of going off on a tangent. There are people who are seeding the questions to sort of stimulate discussions about things like that. And so if you're going to go to a blog or try to find other people who have similar questions or problems, I would highly encourage you to use this one. Because, again, you can find a lot of things on the web, and some of the things on the web aren't that reliable. And this is a tremendous service to have this available where people that are knowledgeable about these diseases are actually kind of taking a peek. They try very hard not to, over-monitor this or redirect the good conversation going on. But if there's information that may not be so accurate on there, they'll help to redirect it. And I think that's a valuable resource that could be very helpful to you.
Yes. In our program book, we have this list of the abstracts. Is there any way we can see those? Are they online as well?
They are going to be online, so we can give you more information about that.
Great.
Thanks. Any other questions? Oh, yes.
I had a question about whether or not the initial site of the infection in MAC, can it come from your sinuses? In other words, having constant sinus infections and having the junk drain down, I mean, I assume like into your lungs as well as the rest of you. Can that be the initial source, or is it always targeted initially in the lungs?
Ken, you want to take that?
And can it go vice versa?
I have to say that we haven't been as good about looking in the sinuses for it, but we do know that it can be there. There have been people, especially ENT folks, who have focused on this and looked for it in the sinuses, and if you look for it, you can find it there. You can find M. abscessus there. You can find MAC there. Whether that's the original site of infection or, most of us are nose breathers, and so if we're breathing in aerosols of this, it would make sense that it's not only infecting our lower airway, but potentially the upper airway as well. And in many people that have known genetic causes for this, like cystic fibrosis or primary ciliary dyskinesia, the upper airway is very heavily involved in the abnormalities of clearance that go on with that. And so we know for infections like Pseudomonas or Haemophilus influenza, it's common to have similar bugs in the upper and lower airway, and it would make sense that mycobacteria would be there as well. But whether that contributes to sort of the route that it passes through for infection to occur, I don't really know that for sure.
I think we have a question. Okay, one more. Yeah.
It's just to do with that. Should you then go to an ENT and have them do, a sample?
I think if you have sinus problems, if you have, frequent nasal congestion, if you're having, headaches kind of in the frontal area or kind of behind your nose, if you're having, a lot of symptoms referent to that, that is part of the respiratory tract. And if that's bothering you a lot, it's worth asking your doctors whether that should be investigated more.
We have time for maybe
Can the
one more
panel
question.
comment? I often hear about questions about stem cells. And just to address that for the group, from patients oftentimes come in and say, what about this? And they hear or see or read about things, and I would just want to share that information with us. Stem cell, I mean, what's the role in bronchiectasis?
None.
Great.
Not so far.
Well, let me just say a couple things about
There
it.
may be something.
There are what I think, scientifically rigorous studies that are being done at this, on this. These are not the ones that are advertising online or advertising on TV. There are a lot of places that are advertising stem cell therapy for a variety of conditions. I would just urge a lot of caution about that. A lot of these institutions have not, don't have a whole lot of science behind what they're doing, and there are some risks associated with that. But from that comment, don't feel like this is not a viable therapy. I think that it potentially is. There are people looking at this for a variety of diseases, including lung diseases, and it may be a viable therapy at some point in the future, but you really want to have it in the medical literature first and hear from it, through the channels that your doctor would know about or be reading, rather than responding to one of the online advertisements. That's the only thing I can say about that.
All right, two more questions. Yeah, yes. Yeah, go ahead. Here's.
After my unsuccessful treatment for MAC, I'm sorry, I'm losing my voice. Several years ago, I went to Mayo Clinic, and since there was no option for me to following any more treatments, I was told that actually there is not enough proof to say that MAC does any damage. It could be just sitting there, but not really doing any harm. Of course, it was a few years ago. Probably fine.
Shannon, you want to just comment on that?
So the question is whether or not MAC, the organism, is really a pathogen or a disease-causing, or sometimes is it just sort of an innocent bystander and not causing problems for patients. And this is the real difficult part with studying patients and treating patients. It truly does become a bit of an art because for some patients, the germ is not disease-causing and they do well or they're stable with the organism, and we deem that we don't think that they need treatment. And then other patients, it's clearly problematic and it causes progression. It can cause dense pneumonia, it can cause cavities or holes in the lungs. So part of that's the host, most likely, and the vulnerability of that patient, and part of that's the actual strain that they have causing disease. So I think that, I don't know if that necessarily answers your question, but just to echo that there is quite a heterogeneity to this disease.
Okay, one last question, I think.
I've had MAC 5 times now, and I have chronic rhinitis. And I was curious about that because I go like 2 years between treatments negative. Could somehow airways breathing in cause it to come back?
Yeah. So again, that gets at the question of why people get these infections. And so if we knew the answer to that and we could address that and prevent it, then you wouldn't have had to be treated for 5 times. But we do know that if you've had a single episode of this and you're treated, even if you're successfully treated, you remain at risk for acquiring new infections. And so it doesn't necessarily mean, in fact, frequently it doesn't mean that your initial treatment was not the right treatment or not successful. It likely was. But whatever caused you to get that first infection, that something that we don't understand as well as we'd like to, isn't gone. And so since these organisms are common in the environment, they're in our potable water supply, they're in our lakes, rivers, and streams, they may be in our soil, we're constantly exposed to those things. And if there's something abnormal about our respiratory tract or the way our immune system handles it, that constant exposure, predisposes you to having those bugs stick in the airway, elicit an inflammatory response, and then start the infection and sort of disease cycle all over again.
All right, well, this has been a great day. Really appreciate the panel, especially and the patients. We really appreciate your sharing your issues with us. I mean, I've learned a lot today, and things that I need to do differently, taking care of my patients. So, thank you so much for coming to this and for participating so well. And we'll wrap it up now. Tim has a final word.
That's right. Yeah. And again, I would express my appreciation for all that you do, and what your activities are really important. I think not only for your health and your choices, but for your other colleagues, other patients, and we certainly value that. You're an inspirational group to all of us, and I encourage you to continue to participate and advocate for yourselves. It really is very, very important to us, and I would express and concur with Dr. O'Donnell. It means a great deal to us, so thank you very much.
So this concludes the day. I do want to express my great appreciation. Our microphone handlers are actually respiratory care practitioners here at Georgetown and staff members. So when some of my patients know them because they teach them the airway clearance. And Riza Peralta, who's my administrator, who's been fantastic, and of course our CME staff. So thank you again. We'll be here for a little while if there are any other questions, and safe travels going home. Thank you.